My name is Zach, and this video will be over SVGs in coronary artery bypass grafts. This is an extensive topic, but I'll be talking about the significance and relevance of them specifically in the Cath Lab. Yeah, and before we get in too deep, shout out to Kern, Grossman, and Watson. A lot of the information is coming from their sources. So before I get into the nitty-gritty, quick refresher, what is an SVG? It's simply a vein taken from the leg and sewn from the aorta to a coronary artery beyond a blockage. And the purpose is to bypass blocked arteries and restore blood flow. So next question, why are they important in the Cath Lab? Well, many patients who come for cath have old bypasses with SVGs. They're known for developing atherosclerosis even faster than native arteries. So SVG failure is common within 10 to 15 years post-surgery, so it's a common thing you'll probably see in the Cath Lab. So this is a extensive topic with many different avenues, but we're definitely going to try and hit basic anatomy, some catheter choices and engagement views and tips, some types of grafts. We got jump grafts, sequential grafts, split grafts, etc. How to recognize those, of course, and also definitely we're going to talk about PCI, embolic protection, no reflow, etc., etc. Let's start with the anatomy. Quickest way to remember for me is just remembering that the lowest is to the RCA. So the most proximal down on the aorta will be the SVG to RCA. The middle will be LAD and diag, and then the highest SVG goes to the OM. This is something you just got to kind of commit to memory. Don't make it too hard. They usually follow this same or similar path, so just remember this picture. Just take a look at these pictures that I'm putting up and just kind of commit those to memory. Look at them, write them if you need, and that's that. Quick test. Can you label which SVG graft goes where? Go ahead and pause the video if needed. Good job. So one thing about the anatomy that you should definitely note is the morphology or takeoff of the actual grafts. So the simplest way to remember is to remember that the RCA, so the SVG to RCA points down, and the SVG to LAD and diag as well as OM point up. Be sure to understand that the pointing upward is progressive, so the middle grafts point upward, and then the OM is even more drastically pointing upward. And that's important to know when we get to catheter selection. Make sure you take a look at this photo from Elias Hanna and just visualize what I'm saying. Okay, so now let's look at graft imaging strategy. But pause, because before we even start looking at the grafts, it's standard practice to do a native coronary angiogram. And the reason is simple. We want to map out the blood flow to the heart muscle. We can check if the native vessels are still open and see if any native branches are filling late. So if there's any late filling, that can hint at occlusions or even competitive flow. So this native coronary angiogram will help us understand whether the grafts are still working and gives us a full picture of the patient's heart anatomy. All right, so next, when it's actually time to engage the graft, the view that you pick matters a lot. So you want a view that's orthogonal, meaning as straight on as possible to the graft's opening or ostium. So here's the general rule of thumb. If you're trying to engage a graft to the RCA, you want to use a LAO view. That's because the right graft comes off the right surface of the aorta, and LAO lets you see it straight on. If you're engaging the left branches like the OM, diag, or LAD, then you, of course, want to use an RAO view. This is good to know as a tech. If you're conscious of what's happening while the physician's engaging and he's having trouble in a view that's not orthogonal, you can suggest a different view. Nice. So once we're properly engaged, the next step is imaging it properly. So we want to know the main views that will get the most of our grafts. So usually the straight LAO or RAO view that we use to get in the graft is perfect for seeing the graft opening and the main body of the graft. But we also want a view that shows the native artery, where the anastomosis is. So the anastomosis is where the graft connects to the coronary artery. We want a different view from our engagement view to really see the disease or runoff. So the recommended views, if we're talking about the OM graft, we can maybe want to use an AP caudal or RAO caudal, and that'll usually let us see the connection clearly. And as for the diag or LAD, we'll use something like AP cranial or shallow RAO, or even LAO cranial. The key idea is you don't just want to shoot one view. You need multiple angles, one to engage and another to show the connection. So usually two works. Okay, so boom. Now that we've engaged and taken our key images, the next step is to analyze how well each graft is perfusing the heart. So our goal during graft imaging is to create a global map of coronary perfusion. Basically, we're matching up the native coronary circulation with the graft flow to see which areas are getting blood and what areas might still be in trouble. Listen up, there's two big questions we ask for every graft. So next time you're at a SVG case and you've done your injections, ask these two questions. 1, is the flow antegrade? Meaning, is the flow moving forward into the native vessel? And 2, is there retrograde flow? So is there flow moving backward up the vessel due to a blockage? Those are the two key questions. So retrograde filling tells us that somewhere upstream there's either severe disease or a total occlusion. And understanding which territories are fed antegrade versus retrograde helps us predict which areas are at risk for ischemia. Now that we know a little bit about the strategy that we'll take and map graft perfusion, the next important piece is catheter selection. If I were to ask you, what direction does a SVG to RCA graft point? If you said downward, you're right. And because of that, we need catheters that naturally point downward to cannulate the SVG to RCA graft. So the most commonly used catheter here is the multi-purpose, the MP1 or MP2. It's considered a workhorse catheter for both diagnostic and interventional SVG work to the RCA. Now, other options include the Amplatz right or the RCB, which is the right coronary bypass. It's a slight modification of the JR4, so don't get those two confused. Now, this is important. This is an important caution. The JR4 catheter, which is usually great for native RCA engagement, is specifically discouraged for vein grafts to the RCA. Can you guess why? It's because the JR4 points up and not down. So using it on a downward facing graft can lead to poor filling, giving a false impression of an occlusion or a stump. Make sure you remember that. So I hope you remember the 3 grafts to the left coronary system typically point upward. So for these, you want a catheter that points upward. So for this case, the JR4 works well for imaging. Other options can include the left coronary bypass catheter or the internal mammary catheter. Both are upward pointing designs to match the graft anatomy. Now, if we're intervening on the left-sided grafts, which can be tougher because of high takeoff and poor support, then the AL is often preferred, the Amplatz left, usually in a larger size like AL2 or AL1.5, because these provide better support from the opposite side of the aorta. Alright, so this video is kind of drawing on a little bit. So I'm going to try and touch on radial access and no reflow. So even though the catheter selection is important, we also have to consider how we're accessing the patient, and it can make a big difference when dealing with bypass grafts. So for radial access, the general principles still apply. Pick the correct orthogonal view for engaging. You choose the same catheters that point in the right direction, down for RCA, up for left system grafts, and you adjust your angles, your imaging angles as needed. But radial access can create extra challenges. Engaging vein grafts from radial access, especially from right radial, can be a lot more problematic than femoral access. Now, why? This is because of angulation and platform issues. Coming from the radial artery, the catheter must navigate sharp bends in the aortic arc. This gives shorter, less stable platform in the ascending aorta. So 2 would be lack of support. Catheters already have a tendency to flop back and fall into the descending aorta. And this is an even bigger problem when working with left vein grafts, which have a higher and more awkward takeoff. Bottom line though, if the patient has multiple left vein grafts or high takeoff grafts, femoral access is usually preferred. If a patient mainly has a Lima graft or maybe a single simple right graft, left radial can be a great option. But avoid right radial if possible when there are important left-sided grafts involved. Alright, so this video is getting a little longer than I expected, so I want to touch on one last major complication that I should probably talk about when talking about vein grafts, and that is no reflow. So no reflow means basically that even after you successfully open a vessel during PCI, the blood flow doesn't properly return through it. It's as if you fix the plumbing but the water still isn't running. So the risk of no reflow during vein graft PCI is actually pretty high, estimated around 10 to 15%. But why does it happen? It's because veins are used to low pressure, not high arterial pressures that they face after being turned into grafts. Because remember, these vein grafts are pulled from the leg. And over time, grafts build up degenerative atheroma, very delicate plaque that's easy to break apart. So when we balloon or stent these grafts, those pieces can break loose and basically plug the small vessels downstream. So the microcirculation. Since we're on the topic of no reflow, I'll touch over embolic protection devices. So to try and prevent no reflow, we often use embolic protection devices, basically like tiny baskets or filters deployed distally to the lesion. So they work by catching the debris before it can basically travel downstream. So here's the catch. You need at least 3 to 5 centimeters of good vessel to safely deploy a filter. So very distal lesions may not be great candidates for embolic protection devices. So before we wrap up, I think it's important to understand long-term outcomes of vein graft interventions. This is because it impacts how we manage these patients beyond the cath lab. Unfortunately, the long-term outcome after stenting vein grafts are poor, much worse than what we typically see stenting native coronary arteries. So the target vessel failure TVF rates are at least 20% at 1 year and then up to 50% at 2 years after an SVG PCI. So drug-eluting stents, which usually outperform bare metal stents in native coronaries, actually do not show a clear advantage in vein grafts. Now this is because vein graft disease is extremely aggressive. So even if you fix one spot, new disease often develops somewhere else in the graft. So there's also an importance of stenosis location. The location of the disease within the graft also impacts success rates. Distal stenosis usually have the best outcomes, usually early after surgery due to intimal hyperplasia. These lesions may do well even with balloon angioplasty. So midshaft disease, intermediate outcomes, and then proximal stenosis are the worst outcomes, with over 50% occlusion rates within just a few years. So as we've seen today, working with SVGs in the Cath Lab demands special strategies, careful catheter choices, and an awareness of unique complications like no reflow. Despite our best technical efforts, the long-term challenges with vein grafts from aggressive disease progression to high failure rates remind us that PCI in these vessels is often just a temporary fix rather than a permanent cure. And by respecting the fragility of vein grafts, adapting our techniques, and thinking ahead, we can give our patients the best chance for good outcomes both inside and outside the Cath Lab. Thank you for coming to my TED Talk.